name is Heun. I'm a consultant psychiatrist and editor of Global Psychiatry Archives, and I'd like to continue our series of Mental Health Explained today with post-traumatic stress disorder and about the diagnosis. So the basics is a severe psychological disturbance following a traumatic event, and the characterization is that there is an involuntary re-experience of parts or the total of the event. And there's symptoms of hyperarousal, so overactivity, avoidance, and emotional numbing. So the symptoms come usually after 6 months-ish, sometimes earlier, sometimes later. They're usually present for at least 1 month and cause significant distress or impairment in social, occupational, or other functioning, so like work. There must be, according to ICD-10 or DSM-5, there must be 2 or more persistent symptoms of increased psychological arousal or sensitivity, which usually shouldn't be there before the event. And there should be difficulties of falling or staying asleep, or could be. There should be irritability and outburst of anger, reckless behavior, sometimes self-destructive behavior, difficulty concentrating, hypervigilance, overactivity, and exaggerated startle response, so which means people startle very strongly in minor events, or if they hear a sound which might they relate to the event. So one other criteria are this persistent remembering, or some people would say reliving of the stressor, and flashbacks. These are intrusive and come when the patient doesn't want it. There can be very vivid memories of the event. They can be related to dreams and distress when people are exposed to things which are similar to the events which cause this PTSD. So there is also avoidance of circumstances which are similar. So people might avoid specific streets, or might not go on a specific or use specific cars because that might be related to the event, or they might not go in specific areas of the city. The interesting part is that there's also sometimes an inability to recall some parts of this PTSD event. Sometimes it's completely forgotten, and so the exposure to the stressor which caused the PTSD is sometimes completely forgotten. So usually the epidemiology is after traumatic events like whatever, rape or major car accident. It's usually around 10% of the of the men, and 20% of the women who develop some PTSD. The usual lifetime prevalence, that's the prevalence or the events in everybody's life, is about 8%, and it's even, as I said, more frequent in women than in men. There's sometimes cultural differences and some differences about the type of stressors. As I said, rape, torture, or being prisoner of war, these are the strongest stressors. Usually one doesn't really know where the biology comes from. Some people have examined the brain in its function or in its structure and have found that the hippocampus or the amygdala are affected. However, that's very, very difficult because you don't know the size of the amygdala and hippocampus, which are usually quite small areas of the brain. But so I think this research is still ongoing. There's some genetic component in the way that monozygotic twins, which share 100% of the genes, have higher concordance or have a higher rate of the same disorder, or in this case PTSD, than dizygotic twins, which only share 50% of their genes. Right, there are other risk factors which can increase the risk of developing PTSD after a traumatic event, which is low education, lower social class, female gender, as I said before, low self-esteem, previous neurotic traits. Some people say Hispanic or Afro-Caribbean have a higher rate of PTSD, a history of psychiatric disorders, anxiety or depression, previous traumatic events might be risk factors. There's some peri-traumatic factors. It's the severity of the event, how threatening was it to the life, was a real life threat, what happened, that was it very emotional, traumatic, and was there some dissociation. So these are factors which may influence the follow-up. Usually a higher IQ, higher social class, male gender, and sometimes, seeing possibly the body of the dead person, if that case is the case, sometimes are a bit more protective factors. So meaning that, seeing something which is very sad and real can be sometimes easier to deal with than having this sometimes fantasies or just glimpses. So sometimes the reality is more protective than fantasy. Right. Comorbidity, depression, anxiety, alcohol abuse, somatization disorder don't usually help. There are other anxiety and stress disorders which are a differential diagnosis, adjustment disorders, or people with depression, OCD, and schizophrenia. So the question usually is that there must be a specific focus of a trauma, a reliving of a trauma, some type of hyperarousal, and some dysfunction following the event or the trauma. Other symptoms are, and there's some repetition in that and some overlap in the definition of these symptoms, is recollections, recurrent and intrusive distressing recollections of the event. It could be images, thought, or perceptions. Dreams of the event can be frightening. Dissociative reactions like flashbacks or acting as if the event would reoccur. Intensive psychological stress when people are exposed to cues which are related to the traumatic events, so seeing pictures or hearing from other events which are similar. There might be marked psychological reactions at exposure to parts of the events or things that resemble the event. There's avoidance of stimuli associated with the trauma, as I said before. Could be streets, could be areas, could be cars, could be specific people. Then there's efforts to avoid these thoughts and feelings, efforts to avoid reminders, so places, activities, or people. And sometimes, there is negative changes in cognitions and moods associated with the trauma, which could be the inability to recall, persistent, exaggerated negative beliefs, which sometimes is most traumatic when people feel that they have been, in some extent, being guilty, maybe by lending someone a car where he had an accident or something like that. So these can be negative beliefs filled with guilt. These might cause to distorted cognitions. Being guilty where more or less the person might not have any real impact on the accident or the trauma. There might be persistent negative emotions. Sometimes, people have lost their interest in other activities or interest in other activities. Sometimes there is a feeling of detachment or estrangement from others and the inability to experience positive emotions. So more or less the summary is of these things that in PTSD there are immense parts of an event which affect the avoidance, emotional numbing, hyperarousal, and changes of cognition, which can affect people for quite some time. I come to the treatment later. Thanks for your interest, and enjoy our series of Mental Health Explained. Thank you.